Now, it is the atherosclerosis which is responsible for 2/3 of the cases. If you do the, what is this procedure? Femoral vein, IVC, renal vein and renal vessel. Okay. So, you give an arteriogram, not vein, venography, arteriography. So, you will find the presence of the stenotic lesion. In about 1/3 of cases it will be bilateral. If the person is a smoker or if there is high cholesterol, they are all the predisposing factors. In the case of the young people, there can be fibromuscular dysplasia, which is the underlying cause. And if it is a bilateral renal artery stenosis, ACE inhibitors are contraindicated. If it is a unilateral renal artery stenosis, ACE inhibitors are the drug of choice to manage the hypertension, is what you have to fundamentally remember. So, any sudden onset of hypertension in a patient without a family history of hypertension should always be construed as a possible secondary hypertension. If the age is suspicious, then you need to evaluate for renal artery stenosis. Because there is a decreased blood flow to the kidney that lead to the development of decreased renal function. There can be an abdominal bruit, especially people with fibromuscular dysplasia. There can be a renal artery stenosis narrow enough that if you put the stethoscope, you will find the presence of abdominal bruit. That's the reason always it's a good practice. Any young individual with hypertension, for that matter any individual with hypertension, always look for the possible renovascular hypertension with abdominal bruit. Stethoscope. But often we forget that orthodox practice of checking the renal bruit in a case of detected hypertension. Why? Because we are all in the modern era of ultrasound, CT angio, but they are all secondary, doctor. When there are nothing there, still you can make out 1 out of the 100 patients having renal bruit. With that you started investigation of renal artery stenosis, then you are a very tight physician who is able to make up even clinically. So when you suspect renovascular hypertension, it is a malignant hypertension, sudden in onset, and it is suddenly worsening hypertension, and a hypertension which is refractory to the standard antihypertensive therapy. They are all considered to be the indicators to suspect the renovascular hypertension, is what I want to underscore to all of you. So how do you evaluate and diagnose? Get a renal arteriogram, and which is considered to be the gold standard. But what is the challenge to do a renal arteriogram? You have to pass contrast. But already renal artery stenosis patient will have urea creatinine elevated. In him to pass contrast is finishing the job started by God. So you are pushing him to contrast-induced nephropathy is the main risk. What is the newer investigation available for you? MR angiography. You can pass gadolinium contrast and can be able to do MRA, and this magnetic digadolinium is not considered to be nephrotoxic, hence it can be given relatively safely in the patients with renal failure. But what is one of the complications of gadolinium? There is a MRA gadolinium induced, what is the entity? Nephrogenic retroperitoneal fibrosis is one complication, rarely it occurs in the people. But that doesn't, that should not scare you to administer gadolinium and take a MRA in a patient of renal failure. You can give still. Captopril renal scintigram is a wonderful non-invasive study if the renal function is normal. But after the advent of MRA and CT angiogram and the nice delineation of the anatomy of the stenotic lesion, captopril renal scintigram takes a little backstand. Backstand is what need to be remembered. After the advent of an online examination, just like now the NEET exam can be taken in the modern way. Are you still collecting tickets for going to airport? Earlier days you are flying to Delhi or Mumbai means a beautiful capped air hostess will give you what you call nicely tucked this thing, and you hold it and show to everybody and say that I am going to Bombay, I am going to Delhi. Nowadays you will go to airport, throw your phone, they will check what is your number and then give a printout of the ticket. You carry the ticket and go in showing your identity card. So now the NEET exam also they made it like catching a flight. And earlier days entrance means early morning you get up at 6 o'clock, pray God, and mother will prepare a light weighted idli, special idli, so that after going to the exam hall you forget the purpose and sleep is not the idea. So if you are being fed with Bombay Upma, then you will end up in a snoring sleep in the exam hall. So and we used to go sharp at 9 o'clock, sit and take exam. Nowadays online exam, just carry it, go there, show your identity, go and sit, and flight takes on, you will get a message. All the aspirants can now start clicking. Click, 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 240 clicks are over, your NEET exam is over. And you come out. And your paper is not same as your next guy's paper. Questions are not same for everybody. It all depends on the relative luck. So the entire entrance scenario has been changed. So also, evaluation of renal artery stenosis also changed. Gone are the days of too much invasiveness. Now we have MRA, CT which can nicely delineate. But however is the sophistication, who has to suspect? CT machine won't suspect. It is you who checked the BP. Array, how come 28-year-old only already developed hypertension? When will she love? When will she marry? When will she produce children? Why hypertension so early? You need to get that high index of suspicion and then evaluate for renal artery stenosis. Then how do you treat if there is a stenotic renal artery? What will you do next? You don't keep a sad face to the patient and say your vessel is stenosed. Nowadays everything is easy like a haircut. You will pass percutaneous transluminal, once more a catheter, put a stent, dilate it, dilate the vessel, good blood flow to the kidney, patient is already, he is jumping, thrilling, enjoying, marrying, producing children later on. So there is a reason percutaneous transluminal renal angioplasty has revolutionized. If your stent is not sufficient enough to maintain patency of that stenotic vessel, then is the indication for surgery. And we use ACE inhibitors, calcium channel blockers, and only conservatively manage if the surgery and PRT are contraindicated. Otherwise the role of the medical management is third line. First line is percutaneous luminal angioplasty, stent placement, second is surgery, next comes the drug management. The last topic for the today's evening is renal vein thrombosis. How does the patient present to you? Typically he is a guy about some 25-26 years who has got nephrotic syndrome in the background. One day he suddenly developed abdominal pain and he is also having hematuria. What is the underlying cause? Severe abdominal pain, hematuria. The reason is nephrotic syndrome is a hypercoagulable state. So he developed renal vein thrombus and that is leading to the hematuria and severe abdominal pain. So nephrotic syndrome is one of the causes. Similarly, any hypercoagulable state like renal cell carcinoma, it can be able to pass through the renal vein and then lead to thrombus. You can see this is the IVC, doctor. These are the kidneys. And what happened to this? There is a thrombus sitting in both the places. Kidney is unable to drain into the IVC. Hence, what happened to the kidney? It became edematous and it developed a lot of collaterals, and through collaterals slowly it is draining out. That is how renal vein thrombosis patients will present. right? And any retroperitoneal fibrosis, aortic aneurysm, any pathology like lymphadenopathy in the retroperitoneum, your renal veins, kidney, they are all located retroperitoneally. So they typically get affected and there can be a thrombus lodging in them. So sudden decrease of renal perfusion leading to renal failure with the flank pain, with hematuria and proteinuria. Why proteinuria? Because renal vein is slowly draining into IVC. Hence the efferent arteriolar pressure became, efferent arteriole drains into venule into renal vein, no? Any increased pressure in the efferent arteriole will increase GFR. Increased GFR will lead to hyperfiltration state of proteinuria, etc., is the presenting feature. You can selectively go and evaluate the renal vein. Selective renal venography will help you to identify the thrombus and anticoagulate the patient, mainly to prevent the renal vein thrombus from going to the lungs and leading to pulmonary embolism, is what need to be ultimately remembered. So that is all the story. Mainly you must know in renal vein thrombosis what are the predisposing factors. Even pregnant women, sudden abdominal pain, hematuria, proteinuria, worsening urea creatinine. Think of pregnancy, hyperestrogenic state is also a predisposing factor for hypercoagulability, is what need to be remembered. So that is all the story of renal vein thrombosis. So doctor, today we will take a break. Post-viral syndrome we are all suffering, both teacher and students, good number of students. So we will excuse ourselves for today, and tomorrow we will finish nephrology, so that next week we can briskly start hematology, is the plan. Thank you.